A very good afternoon, students, and today we are going to do the last part of the aminoglycosides, and that will be part 4, and we'll be dealing with individual aminoglycosides. Now, the first aminoglycoside which deserves a mention and which is the prototype drug, students, of this class is gentamicin. Now, gentamicin is one of the cheapest aminoglycoside available. It is low cost and it is quite commonly used in a developing country like ours. It is isolated from Micromonospora purpura because you can see that these two I's mean that the I and I means not Y here, means that it is from Micromonospora. It is now never given orally. It is always given intramuscularly or intravenously in severe infections which are caused by gram-negative organisms. And these gram-negative organisms mean, when we are talking about gram-negative aerobic bacilli, students, we mean Pseudomonas, Enterobacter, Proteus, Acinetobacter, Klebsiella. So these are the gram-negative organisms. Gentamicin can also be given as a topical preparation for creams, ointments which contain about 0.1 to 0.3% gentamicin sulfate. And this can be applied on the treatment of infected burns, wounds or skin lesions. I told you, whenever there is infection on the burned skin, the organism which colonizes produces green colonies, and that is a pseudomonas infection, and for treatment we have to give the aminoglycosides. Although I have not mentioned in this slide, but since we are talking about the preparations of gentamicin, one of the specific drug delivery routes of gentamicin is via the use of the gentamicin beads, and these beads are implanted in the bone and they are useful for the treatment of osteomyelitis. In chronic osteomyelitis, it is very difficult to eradicate the organism, and that could be a gram-negative colonization. So for that, because the drug will not be able to achieve concentrations in the bone if we are giving it intramuscularly or intravenously, so in that case we can give it in the form of local drug delivery, where they are formed in the form of beads, BEADS, gentamicin beads, which are used for the treatment of chronic osteomyelitis. Gentamicin can also be given for intrathecally for treatment of gram-negative meningitis, and as I told you, it can be administered intraventricularly also for treatment of CNS infections, but this route is usually not preferred. Again, I would like to tell you it is the least costly aminoglycoside, and yes, it is quite commonly used, and its loading dose is 2 mg per kg, and then you can give it to 3 to 5 mg per kg per day. The once daily dose is 5 to 7 mg per kg, and the injection can be given over a spaced interval of 30 to 60 minutes for patients with normal renal function. So these are the dosing of aminoglycosides gentamicin, and now we come to the uses of these individual, or first and foremost gentamicin. Although these aminoglycosides can be used interchangeably, gentamicin, tobramycin, amikacin, netilmicin, they can be used interchangeably. Among this, I have not mentioned kanamycin, which is also an aminoglycoside, but kanamycin is used as a second line therapy for tuberculosis. Otherwise, it is supposed to be a very toxic aminoglycoside with respect to ototoxicity and nephrotoxicity, that it is usually not given for gram-negative aerobic infections. Just because of its toxicity, kanamycin is reserved for the treatment for tuberculosis, again as a second line agent. For all other aminoglycosides can be given interchangeably. So the first use I want to discuss is the treatment of urinary tract infections. The complicated upper urinary tract infections, complicated pyelonephritis is one of the indications for the use of aminoglycosides, because for lower uncomplicated urinary tract infections, we can give fluoroquinolones, we can give the extended spectrum penicillins, we can also give the sulfamethoxazole and trimethoprim combination. But where there is a problem of a complicated urinary tract infection or upper urinary tract infection, we would not like to take any chances. Rather, we would like to give a drug which accumulates nicely in the renal system, and gentamicin becomes the obvious choice. The most common causative organism which is responsible for causing urinary tract infection is E. coli, students, and gentamicin is very susceptible. Would be killing the E. coli, and the person will get some relief from the urinary tract infections. They are usually not indicated for the treatment of uncomplicated urinary tract infections. So they have a good role to play as far as the complicated urinary tract infections are concerned. Second use of these group of drugs is pneumonia, but it is not pneumonia which is a community acquired pneumonia. It is a pneumonia which is hospital acquired in nature, or a pneumonia which is seen in immune compromised patients, pneumonia which is seen with ventilator associated pneumonia, VAP it is called in short. The gentamicin like drugs are effective for treatment of this kind of pneumonia. The community acquired pneumonia is caused by Streptococcus pneumoniae or anaerobes, for which we give the respiratory fluoroquinolones and not the aminoglycoside, students. Even in the treatment of ventilator associated pneumonia, hospital acquired pneumonia, the aminoglycosides are never given alone, because we expect less passage into the lung tissue of these drugs because of their water soluble nature. So they are conveniently combined with other drugs which are effective for Pseudomonas. In that case, we would like to consider here the beta-lactams which are effective for Pseudomonas. They are called the anti-pseudomonal penicillins: carbapenicillin, ticarcillin, azlocillin and mesdocillin. So aminoglycosides can be combined here with the anti-pseudomonal penicillins, or they can also be combined here with the third generation cephalosporin, and cephalosporins like ceftazidime, ceftriaxone, you're yet to learn about them, have very good activity against the gram-negative organisms which can cause pneumonia. So they are ineffective for treatment of community acquired pneumonia, as I told you, and for hospital acquired ventilator associated pneumonias, they are usually given in combination with the anti-pseudomonal penicillins, which will be the beta-lactam class. So that is what I was telling you, treatment of pneumonia caused by Pseudomonas aeruginosa. The third use of aminoglycosides, of course, that is a limited use, is for the treatment of meningitis, which can be caused by gram-negative organisms. Herein, because of their inability to cross the blood-brain barrier, they are not the drugs of choice. And if you want to have their good concentrations in the brain, I told you have to give the intrathecal route, or you have to give the drug intraventricularly. But that is a very sophisticated, not such a simple way of drug administration. So we have effective drugs available, so we'd leave aminoglycosides from here. So they are not the drugs of choice. So infections which are caused by gram-negative organisms resistant to beta-lactam antibiotics, there we can think of giving aminoglycoside, but they are not the drugs of choice for gram-negative meningitis. And if at all we have to give aminoglycoside intrathecally, we have to choose 5 milligram of a preservative-free formulation of gentamicin, or any other equivalent dose of another aminoglycoside, which is administered directly intrathecally once a day. So preservative-free formulation will have to be sought from the pharmacist to do the needful. The aminoglycosides like gentamicin, tobramycin are also associated with the peritonitis, which is associated with repeated peritoneal dialysis in patients who are having kidney failure. So this is one of the complications of dialysis. So aminoglycosides can be used for peritoneal dialysis associated peritonitis. One of the uses I've already embarked upon is its use in bacterial endocarditis, and I told you that it is effective for enterococcal endocarditis, and endocarditis which is brought about by Streptococcus viridans group. So they can be useful here. So low dose gentamicin 3 mg per kg per day in 3 divided doses. Here you will not be giving a once daily dose, you will be giving 3 divided doses with penicillin or vancomycin. That is a cell wall active agent. Penicillin is a cell wall active agent, vancomycin is a cell wall active agent. For 2 weeks, the therapy could last up to 6 weeks for enterococcal endocarditis. So this is one of the important uses of the aminoglycosides in general, the drugs which could be used interchangeably. Now I would like to throw some light on one of the drugs which was discovered first from the aminoglycoside class. The name of the drug is streptomycin. Streptomycin is usually not given for any gram-negative aerobic bacilli infections. It has reserved uses. It is a second-line drug for the treatment of Mycobacterium tuberculosis infection, for which it is given intravascularly in the dose of 0.75 milligrams. It's no longer the drug first line therapies, because we have drugs which can be given orally, drugs which are more efficacious than streptomycin. But nevertheless, the aminoglycoside class, kanamycin, amikacin, have been reserved as a second line agent for tuberculosis. Streptomycin has its utility because streptomycin can also be used for other atypical rare infections in the form of plague. It can be used for brucellosis. It can be used for tularemias. So these are some of the indications, some rare diseases which can colonize a man, and streptomycin might be useful. And streptomycin is obtained from Streptomyces druseus, and that is why the MY here and the MY here. It is used as a second line agent. I already told you the dose of 0.5 to 1 gram per day, intramuscularly or intravenously, not as a first line agent, but has some role to play in non-tuberculous infections also, in plague, tularemia, sometimes in brucellosis. They can be given along with, in combination with tetracycline. And of course, if you don't have any other aminoglycoside available, you can combine it with the cell wall active agent penicillin with streptomycin, which can be effective for enterococcal endocarditis, and a 2-week therapy for streptococcal viridans endocarditis. So streptomycin does have its own share of side effects also, over and apart its sheer toxicities with aminoglycosides. I told you it can cause optic neuritis, it can cause emergence of scotomas or blind spots, which are seen students with the streptomycin usage. Streptomycin is least nephrotoxic, that is its positive point, but it is most toxic on the vestibular system. It does cause lot of vestibular system abnormalities. It can cause vertigo and loss of balance. So it is most vestibular toxic out of all aminoglycosides. When I am saying that, it means it has a preferential vestibular toxicity. The word preferential is important. It sometimes asked in the examination also to you. As far as tobramycin is concerned, its therapeutic uses are same as that of gentamicin, and it can cause nephrotoxicity and ototoxicity both, and that may be less toxic to the hair cells in the cochlea and the vestibular end organs, and cause less renal tubular damage than gentamicin. So tobramycin may have less nephrotoxicity than gentamicin, but yes, the clinical data supporting that is scarce. As far as amikacin goes, it is one of the broadest spectrum aminoglycoside, and the unique part of amikacin is that it is resistant to almost all aminoglycoside inactivating enzymes. So if a strain of a gram-negative bacilli is not responding to gentamicin, it will respond to amikacin. So amikacin is a reserve aminoglycoside class. It is semi-synthetic in nature, but the good part about it is that resistance develops very late to amikacin, or it is not commonly seen in the bacterial population. It has also a special role in hospital, usually used for hospital acquired infections. That is about amikacin. And then we go to neomycin. Neomycin is the most nephrotoxic aminoglycoside. Students, remember this thing. Neomycin is an aminoglycoside, but it is never given intravenously or intramuscularly. The reason is very clear, because it is going to damage the kidneys to an extent that there is no purpose in giving neomycin. Of course, neomycin is available as topical ointments to be applied on the burnt skin or on infected boils or ulcers. It can be given. It brings about respite and clearance of the bacterial infection for local wounds. But yes, neomycin has one oral indication, students, and that is for making the gut sterile. Now, when do you want to make the gut sterile? You are giving neomycin because we know that aminoglycosides don't get absorbed in the gut. They are so polar, so they remain in the gut. They suppress the gut flora, and suppression of the gut flora is what we mean by bowel sterilization. Bowel sterilization means that you want to make the gut, which is usually inhabited with a lot of flora, you want to make it sterile if you have to go for some surgical procedure, or you want to go for from radiological examination. You might want to make the gut sterile, and that is the case. We can give neomycin-like agent 1 day prior to the investigation to make the gut sterile. For this purpose, that neomycin is going to remain in the gut flora. It is going to suppress the gut microflora. It is used for the treatment of hepatic encephalopathy because neomycin is going to suppress the gut flora. This gut flora is important for formation of ammonia, and that could worsen in hepatic encephalopathy, which can be seen in such patients. So neomycin has two uses: one to sterilize the gut flora, the gut, by inhibiting the gut flora, and secondly by decreasing the production of ammonia in patients of hepatic encephalopathy. The generation of ammonia is dependent on the gut flora. So if because the patient is already having an hepatic failure following cirrhosis, that ammonia will not be detoxified. It is going to get contributing to the hepatic encephalopathy, which will be seen. So to minimize that, neomycin is used. We can also use lactulose for the same reason, but yes, neomycin has two uses, as I told you. So let us have this MCQ. Which one of the following statements about neomycin is correct? It is used as an adjunctive use in treatment of tuberculosis. It is drug of choice for Rocky Mountain spotted fever. It is a least nephrotoxic aminoglycoside. It is metabolized by hepatic enzymes, and it is used in hepatic coma. So first four alternatives which you see, it is not used as an adjunctive treatment for tuberculosis, never meant for systemic disease, whether it is tuberculosis or whether it is a pseudomonal infection. I never told you this given for that. It's not used for tuberculosis. If you want to give for tuberculosis, we select either amikacin or kanamycin for that matter. We do not select neomycin because of its nephrotoxic potential. It's not the drug of choice either for Rocky Mountain spotted fever. These fevers are caused by rickettsial microorganisms, and I told you that aminoglycosides do not have any activity against rickettsial microorganisms. It is the most nephrotoxic, not the least nephrotoxic aminoglycoside. It is metabolized by hepatic enzymes, and it is not metabolized by hepatic enzymes, and it is only used for hepatic coma. So this is the correct statement, the fifth statement out of all. Which one of the following drugs is most likely to be effective against multi-drug resistant strains of mycobacterial tuberculosis, including those resistant to streptomycin? The answer has to be the unique aminoglycoside amikacin, because it is resistant to most aminoglycoside inactivating enzymes which are generated by the resistant bacteria. So that is about it. That is, we have amikacin, neomycin, and gentamicin and spectinomycin. Spectinomycin is not used for multiple drug-resistant strains of tuberculosis. It has just one use in the treatment of gonorrhea, and that gonorrhea which is in patients in which we cannot give penicillin because the patient is allergic to penicillin. So spectinomycin has very limited uses. Here the answer is going to be amikacin. So spectinomycin is related to the aminoglycoside in structure, but its use is confined to the treatment of gonorrhea in patients who are allergic to penicillin or in those whose infections are caused by penicillin-resistant gonococci. So a single dose of 40 mg per kg up to a maximum of 2 grams is given. Only single dose therapy is given, that is for spectinomycin. So this is students, he is Salman Abraham Waxman, who discovered Streptomyces bruceus, and he was awarded the Nobel Prize. And in this era of uncertainty with COVID-19, where we do not know which treatments are going to work, we must respect what the discoverers did. He discovered tuberculosis treatment as in the form of streptomycin. Similarly, we are in desperate need of a person to discover the treatment for COVID-19. So all these discoverers, definitely they were men of grit. Which of the following antimicrobials show time-dependent killing? I told you that fluoroquinolones and aminoglycosides, they both show concentration-dependent killing. So the beta-lactam antibiotics or the cell wall active agents, they show time-dependent killing. So ofloxacin, students, you know, is a fluoroquinolone. Gentamicin is a fluoroquinolone. Ciprofloxacin is also a fluoroquinolone. So that is it. So ceftriaxone is one such drug which shows time-dependent killing. So which of the following antimicrobials shows time-dependent killing? The answer is ceftriaxone. The beta-lactam antibiotics, so ceftriaxone belongs to that class, shows time-dependent killing. So thank you, students, very much for coming and listening to my class on individual aminoglycosides. That was left, I couldn't complete it yesterday evening. One more thing, students, I would like to tell you here is something about the drug repurposing. You know, what is drug repurposing? If you think, it is very simple. You know, the drug may be approved for one certain indication. For example, azithromycin is approved for Legionnaires' pneumonia. pneumonia. Azithromycin is approved for H. influenzae. Azithromycin is approved for pertussis. Similarly, if we talk about hydroxychloroquine, it is approved for rheumatoid arthritis. It is approved for inflammatory diseases like systemic lupus erythematosus. Chloroquine, for that matter, it is approved for malaria. But you know, when these drugs, they find other indications for which they are not yet approved, that is called drug repurposing. Why I'm mentioning you this? That in the era of COVID-19, we have not been able to discover a drug molecule, you know, which in such a short span of time, which is going to be having coronavirus killing action. What we have this point of time are the available drugs which show some activity, some anti-inflammatory activity, some antiviral activity. So we are trying those drugs for COVID-19. So all the drugs which we are considering at present for COVID-19, for which the clinical studies are planned worldwide, are directed as drug repurposing. One drug which is indicated or used since long for one indication, so hydroxychloroquine for rheumatoid arthritis, is now being thought as one of the drugs for management of COVID-19. So we need to have proper studies in that regard. We have the drug molecule. We don't have to go for the preclinical studies or phase 1 or phase 2 studies for that molecule, because we know its efficacy, we know its safety. What we don't know is its efficacy for COVID-19. So that is called drug repurposing, and that is what the scientists are thinking about today. We want to study the drugs for COVID-19, hydroxychloroquine in one arm, the antiviral drugs in one arm, interferons in one arm. So like that, we have the scientists are planning to study the different drugs which are available for other infections for COVID-19. So in this short period of time, that is what can be done, and that if the intention is good, it will benefit the mankind. Thank you so much, students, and I would come soon again with another antimicrobial in which you would be interested in. Students, continue to read. Don't waste this time. I know you may not be very motivated sitting in your homes, but yes, once you have to be a lifelong learner, you have to have your own motivation to learn. Thank you so much, students, for a patient hearing. Thank you so much.